my name is Melanie Amos and I am a lead physiotherapist in the Thames LTV network. And today I'm joined with Jess Thomas, who's a paediatric consultant, and I'll let her introduce herself shortly. And today we'll be talking about the management of a respiratory deterioration in that paediatric patient, and including the role of physiotherapy.
Great, so I'm Jess Thomas, paediatric consultant at Woolwich, and we're going to use a case-based approach. So let's start with the first case. So this is a 12-year-old boy with severe cerebral palsy, so GM-FCS5. He's got drug-resistant epilepsy on 3 anti-epileptics. He's also got dystonia. Last winter, he had a prolonged PICU admission, and it was tricky to get him off the ventilator then. And since then, he's had 3 admissions on our HDU with chest deteriorations, each time requiring Optiflow. So he comes into resus, pre-alert. He's had 3 days of cough and increased secretions. Started on oral antibiotics by the GP. And then today he's been having increased seizure frequency. And he had a prolonged seizure this morning requiring buccal midazolam given at home. LAS arrived and he was still fitting, so they gave him IM midazolam as per their protocol. So he's come into resus and the seizure's now terminated, but he's got severe work of breathing and he's very hypoxic. So we're going to do an A to E assessment in resus. So A, he's quite stertorous, lots of snoring sounds, and he's also got some stridor. From a breathing point of view, he's saturating only 90% on 15 litres of oxygen. He is tachypneic and he's working very hard. Poor air entry throughout his chest, and mum's worried because he's not coughing at all, and that's always a bad sign for him. Moving on to C, he's tachycardic, and his blood pressure is within normal range for his age. And D, so he's got low-grade pyrexia and he's really not very responsive. So he's been very knocked off by the benzos that he's had. So he's probably somewhere between V and P on the AVPU score. And E, you expose him, there's nothing really to find. You see that he's a peg-fed child and everything else looks healthy. So moving on. So this is the portable chest x-ray that he has done in resus, and you can see it's pretty uninterpretable from a kind of collapse consolidation point of view. But the main thing to see here is that this child's got severe scoliosis, which means that he going to have some very severe restrictive lung disease, and that will make him very difficult to manage from a respiratory point of view. We stick a cannula in and we get a venous gas here, which unsurprisingly shows that he's got a respiratory acidosis, but it's not terrible. His lactate is a bit raised and he's probably getting a bit dehydrated, reflected in his hypernatremia from all his secretions and his pyrexia. So let's have everybody's ideas. How would you've got this child who's very unwell in your resus. Tell us what your management would be.
So great, we're looking at saline nebs, great. Start high flow oxygen, sort of antibiotics, mucolytic management, chest physio, yes, that's why I'm here. Chest physio, brilliant. Saline nebs, suction, positioning, yes. Nebs, high flow nasal cannulae, 15 litre non-room breathe mask, all of these brilliant ideas. We'll give a few more seconds for people to put some things in. It's just starting that thinking. You've got that patient in front of you, and then we'll go through what we've thought of as well, and some extra bits, go elaborate on some of those points as well. Thank you for those extra ones that have just come in. Dexamethasone, nebulized adrenaline, all of these great ideas, and we're going to discuss things a little bit more now as well. So great, thank you for everybody.
Great. So let's go through the management then. So lots of people talked about respiratory support. So actually, LAS had put him on 15 litres via non-rebreathe, and he still saturating 90%. So, and with severe work of breathing. So he probably does need a bit more respiratory support, although obviously all the other things we're going to do, like physio, suctioning, nebs, should help him as well. So we can try putting him on high flow nasal cannula, so some Optiflow, and that has the advantage that it will be nice, warm, humidified oxygen, which should help with his secretion management. But actually, a child like this with such restrictive lung disease may need to escalate the respiratory support. So he may need some PEEP, so you may want to put him on CPAP. And he may even need escalation to BiPAP if that's something that you do on your unit. Yeah, so we talked about nebulizers. Mel is going to talk more about nebulizers, but actually if he's having very thick secretions and not coughing, we may want to give him some hypertonic saline, so 3% and even 7% to break down those secretions. So we wouldn't tend to use 7% in a child who doesn't usually have 7%, but often these children with complex neurodisability and previous chest problems may have a physio plan. So you can ask parents which nebulizers work well for him. If you are trying 3% saline for the first time, it can trigger wheeze. So I would usually use try with a bronchodilator, and Atrovent also has the advantage that it dries up oral secretions, and that will hopefully help to some extent with the oral secretions that he may be aspirating. Antibiotics, yeah, that's a kind of, lots of people said that's a no-brainer. I mean, it's probably been triggered, this has probably been triggered by a viral infection, hasn't it? But we're talking about a very unwell child and a child that's at risk of secondary bacterial infection. So you would follow your own microguide, or you may well have previous sputums with sensitivities. Often these children grow things like Pseudomonas, Serratia, so you may want to look at what his sputum has been sensitive to before. Feeds and fluids, so we need to keep him hydrated somehow. Whether to start feeds or fluids, it depends on how he's doing, really. If you think there's a chance that he might get intubated in the next couple of hours, then it's a good idea to start IV fluids. Otherwise, he's got a PEG, so you know, as much as possible, we try to keep providing fluid enterally for these children. So you might want to run some continuous diurolite very slowly, and then once he's more stable, kind of introduce a bit of milk. You would certainly keep him fluid restricted because of kind of his respiratory condition, but also remember that he's going to have lots of insensible losses because he's pouring with secretions, and he's also pyrexial. Investigation, so we would send viral swab for this child's sputum, and bloods may or may not be very useful, but someone will have sent them when they put the cannula in. And it will be useful to see what his inflammatory markers are. And then absolutely key to this is whatever time it is, day or night, is getting the on-call physio in, because this is a child who is not managing his secretions, is not coughing. And if we don't do something about that, he will certainly end up being intubated. Mel.
And just to say at this point, some of you may not have physio and you may not have that service. So I'm new to the Thames LTD network, and I've been doing a gap analysis, and some hospitals don't have access. So what I'm going to talk to you about now is, yes, if you've got an on-call physio, they've got a great skill set to come and support you with this patient. But then if you don't have a physio, what I'm going to give you now is some things that you can start doing before the physio arrives, or the physio can help you with that when they arrive. But you call an on-call physio, and depending on what hospital you're in, you could wait up to 45 minutes for them to come in. And in that time, that child could start deteriorating. So I was thinking in this presentation of, yes, it's great if you've got the option of a physio to call, but while you're waiting for a physio, what kind of things can you start to do? So this is my next slide. So I love the mucociliary escalator. And if you want to know more, I've done a whole presentation with Atos on the mucociliary pathway. But we need this lovely, healthy mucociliary escalator in order for the phlegm to come up, the secretions to come up and be wafted up by those lovely cilia and a nicely hydrated mucus to bring it all the way up so that they can be coughed up more easily. But we know this cohort of children often have issues with coughing and with lots of parts of the pathway. So today I'm just going to briefly run through some of those things that could be affecting this patient that we're discussing today. So humidity. We want to make sure that the airway is nice and humid so that we can get those cilia beating, we can help with that mucus coming up, we can get that mucus nicely hydrated so that it can come up those pathways nice and easily. So dry oxygen is our nemesis at this point, anything dry going in. So that's why we've talked about getting that humidity, get that warm, moist air coming in so that our airways can conduct much better and get that mucus out and support that patient with that mucociliary clearance. We've talked about nebulizers. I'm a big fan of the hypertonic saline. As Jess has mentioned, there are some things that you need to be wary of with the bronchoconstriction. 0.9% is not something that I'd use as much. In our next case study, it's a trachea patient, yes, but with a child that's got a normal nose and mouth, the 0.9% can help with a bit of moisture around the nose and the mouth, but doesn't actually get that much deeper into the lungs. And that's when the hypertonic comes into its own. And that's when it can get down and it can help pull those secretions into the main airway so that they can come up your trachea and then they can be coughed up more easily. This cohort of children do have a cough, but it's normally that they are insensitive because they have a lot of secretions there a lot of the time, and they become the cough is less sensitive to normal. So that's what we need to get. We need to get things moving, and we need to get that cough working, by helping it along the way, by pulling those secretions up that airway, pulling them that little bit higher can help support it. And then with the other things that we can do as well. And we've spoken about some of the other things that you can add in, and some of the people in their management plan also mentioned some of the other nebulizers you can give. If you haven't already sent off a sputum sample, sending off a sputum sample is great. So we're waiting for the physio. We've nailed the humidity. We're making sure that there's not dry oxygen going in there. We've thought about nebulizers. Do they have a plan already? Should we start the nebulizers? What strength are we going to start? Have we looked at bronchodilators? If need be, sputum sample, get that up. If not, when the physio comes in, it's something they can do, but you can do that at any time. But sometimes with the physio, they can move things a bit more easily if there are not enough secretions coming out at that point. Suctioning, this child might already have a suction machine and might already have a suction plan. So I will show at the end of the presentation a suction plan. So they might already have that, they might not. So if they've come in their frequent flyer, hopefully that somebody would have done that, and that tells you the depth and the size of the catheter to be used. It might be that they just need it orally. There might be a child that can cough it up to their oropharynx, and you can do an oral suction, or it might be that you need to do a deeper suction via the oropharynx or the nasal pharynx. So the depth is dependent on whether you've got the competency to be able to do it. So working with the MDT, with the nurses, doing an oral suction, a deeper suction does have more risks that are associated with it. But as long as you've got the competence and the confidence to be able to do that, suction, clear that airway. Secretion management, we have talked about this, Jess touched on it before as well, thinking about what medicines are they on that could be drying up those secretions, because we want things to be moist and to move up that mucociliary escalator and move up so that we can get their secretions out and air in. So are they on anything that could be drying it up? There used to be another medication that sometimes you still see patients have hyacinth patches behind their ear. And having a look for those, and the glycopyrrolate as well. That thickens things up, and then it'll make things harder to move. And that might be something later on you need to bring back into their management plan if secretions are too loose. But at this stage, the glycopyrrolate is very useful to know if they're on it and what we can do to support that by taking them off that, and positioning as well. I'm going to go a little bit more into positioning because I think this is a key thing that it's such a simple thing to do, and it makes such a big difference to this cohort of patients. So why do we do positioning? VQ matching, sputum clearance, increases lung volumes, decreases work of breathing. So many patients I've come to see on call and during the day, and they're supine. And it's really convenient to have them supine, but it's not so great for their secretions. Everything is flat, everything is against gravity. So not the best position, great for access, great for being able to care for a child, but when we're talking about all the purposes above, it's not going to help with the sputum clearance. It's not going to help with increasing those lung volumes particularly. So we want to try and see what other positions we've got. Side lying, well, that's great because that means that the diaphragm can move a little bit more easily and the abdominal content a little bit lower. They can load the diaphragm slightly, so therefore you're in a good position to be able to breathe. Prone, how many people have heard about the prone positioning in COVID? Prone positioning is brilliant as it improves the anterior chest wall stability, and it's really helpful for those posterior areas of the lungs, because we know we have more lung posteriorly than anteriorly, so we can get those posterior parts of the lungs to be working. Sitting is a good one as well. I don't mind sitting in a good position, and some children have amazing supportive wheelchairs, so as soon as I can, I'm getting them out in their wheelchairs to change that volume. At this point, when you've got the child that's come in unwell, you probably would have them in a bed, but it's quite tricky to get them in a good high sitting position, especially if they're scoliotic. And despite pillows, it's quite tricky to get them in that great position. So a lot of the time we're looking at that side lying position, but there are multitude of positions that you can use. And this is just an example of what happens. High sitting, you're draining the top parts. Really basically, side lying, you're draining the middle parts, and when you're on your tummy, you can drain those posterior areas. And it is very dependent on the child and their specific needs. So as Jess showed in that chest x-ray, we have quite severe scoliosis. So this child, all these positions would have to be modified. We have a rule of no tipping, because there were some studies that were finding that when you tipped, when I say no tipping, that's head down tipping, which used to be used. But then we found that a lot of the children were refluxing, and that was causing more problems. So there are certain circumstances when you can do tipping, and they're very few and far between. And there is a study going on looking at children that are on free drainage and could they have head down. But as I say, that's very few, and that's on the occasion, rather than the general rule is no tipping, but putting them in different positions. And even a slight change of position of sort of 20 degrees with leaning on a pillow side lying or back slightly on sideline can make a big difference on where they can ventilate. And especially these children that their anatomy isn't like these lungs here, it's not in this position. And also, as scoliosis has occurred over time, different parts of the lung are going to be compressed, and different areas are going to have, you're more likely to get those secretions pooling in the area. So you've got your patient, you've done as much you can, you've called the physio, and you're coming back in for reassessment. And Jess is going to come back in for this bit.
So let's reassess then. So airway is now patent. He's not now making any upper airway noises, which is great. And from a breathing point of view, we've actually put him on CPAP now via a oronasal mask. So a mask that goes over his mouth and nose. He's on a PEEP of 8, and we're managing to wean his oxygen a bit. So he's saturating acceptably on an FiO2 of 55%. He's still tachypneic, but a bit less so, and his work of breathing has improved, but is still significant. He's still got secretions throughout. His heart rate has come down a bit, but still on the tachycardic side, and his blood pressure is within normal range for his age. He's afebrile now after some paracetamol, but he's started to get quite dystonic as he's woken up a bit from his benzos, and that's affecting how he tolerates the NIV. So on mum's suggestion, we've given him a PRN dose of clonidine as part of his dystonia plan. He's now got quite an erythematous face and chest, which is due to dysautonomia associated with his dystonia. And he's got now a mildly distended abdomen. So our nurses just reminded us that it would be a good idea to put his peg on free drainage, because we're now giving him lots of PEEP especially through a full face mask, and that's putting lots of air into his stomach. So our physiotherapist has now arrived on the ward.
One of the big things with physio management is to treat or not to treat. And I think that is something that you need to be aware of. And some children, it's knowing when to stop. So when you have some children that have a lot of secretion management issues and they've got a lot of secretions coming out, if you do too much physio, and there can be too much physio, you tire them out to the point that you tip them over. So it's important to be efficient and effective when you're in there, and especially when you're hands-on, less with this patient, but with the later patient who is younger, the second patient. When you are sort of doing stuff with them, they can get quite distressed, and that work of breathing can go up. So you want to make sure when you're in there, you're being efficient and effective in a period of time. And sometimes you need them to rest before you come back in and do another session. So it's making sure you don't tire them out with physio, but you do need to help remove those secretions. So efficient, effective, short treatments rather than prolonged treatments are the way to go. And that's why if you can have that MDT approach where when you've come in as a physio, if it is in the night and they've already had some of these things done, with the positioning, with the suctioning, with the nebs, with the humidity, and then the physio comes in, the mucociliary pathway is already in a good place for you to help with the extra thing. So with physio management, I'm not going to go into it in too much detail because I can give a presentation on each one of these topics here. But I just wanted to highlight, if you have a physio that can come in and support you, great. If not, you've done the bits that you can do, that you're competent to be able to do, and you've got, then you can be contacting STRS or the anaesthetist to support you. You've got a physio, they've come in, brilliant. What can they do? Well, we've already said a lot of the things that they would be doing, but they can do that detailed respiratory assessment. I know it seems like we're going over things, but the physio can have another look at the arterial blood gases, the chest x-rays, checking a sample's taken, checking those medications, making sure, and I'm sure it's already done at, you know, gold standard treatment, but sometimes things get missed. So it's good to have another person to review that. And looking at those things that we've just talked about, humidity, no dry oxygen going in, because that's going to dry out those secretions. Nebulizers, have we got the right nebulized solutions going in? Are we suctioning? Not only are we suctioning, how are we suctioning? What depth are we suctioning at? Positioning as well. What position are they in? And then you've got those physios that might be advanced knowledge on ventilation. And quickly going through some of the advanced airway clearance techniques that a physio could do. You might have seen physios coming in doing your manual techniques, your percussion, your vibrations, your being able to assist them with a cough. They might be able to have equipment. This child might already have equipment that's been prescribed for them by a physio, and they might have something that you might know as a cough assist, a manual insufflation exsufflation device, to be able to help those secretions move. This cohort of patient, it's a bit more tricky with those machines because you need a lot of compliance to be able to get these machines to work effectively and efficiently, but it has worked with some patients in some case studies. Positive end expiratory pressure, that's got some evidence in the Cochrane review of being able to help remove those secretions. And if you're lucky enough to have a vest, that's a vest that can be put on that helps with mobilization of secretions. It's a bit like a washing machine and just kind of helps move those secretions up. And these are the things that a physio can add in to all those things that you've already managed to do. I've taken a airway clearance plan, suction plan from one of the St George's patients, and this is an example of what you could do. This plan might already be in place, or it might be that the physio writes the plan, but it just shows you what you can do and how you can time things with nebulizers, with physio, with the techniques. And it might be that if you don't have a physio, maybe the carers or the parents could do the physio, and you could help with these other areas of things, such as the nebulizers and the timing of things and the suctioning. And then I always like to have a suction plan. It just tells you the size and what route you're going to have it, and the maximum depth and the duration of it. So these are guides and are totally adapting to each patient. Just touching on nebulizers, because I know we've mentioned them a couple of times. As we mentioned at the beginning, I'm part of the long-term ventilation team, and this is a guideline that we have that's available for everyone to use. The reference is down at the bottom, and this is just a screenshot of how they show you how to put the nebulizer into a ventilator circuit. So this is, of course, a long-term ventilator, ventilation that we would use. It will work on all the different ventilators. You could use an air compressor, so you would use that with a T-piece, and you could just do it with a face mask. But as somebody's already noted in the chat, so they're on a PEEP of 8. So you want to be thinking, do I want to be taking them off that PEEP? Work of breathing will go up for them to have a nebulizer. How might I be able to add it in? So my preference would be using it with a T-piece connected, and you're using an air compressor. You can use a Parry Boy or any air compressor to be able to push that air through to get that nebulizer working. Or if you're in the hospital, you can use the walled air or oxygen going through. But just make sure when you're doing that, if you're putting oxygen through, make sure that's put on the OBS charts as well. There's mesh nebulizers as well that a lot of people have access to now. You've got your Aerogen nebulizer that can go on the humidified part of the circuit. So it can add into that humidity with that nebulizer going through, or they hopefully wouldn't be on a dry circuit, but that just shows you in one of the pictures how you can add it into the tubing if they don't have a humidifier in their circuit. So you've got 2 different types. If you've got the mesh nebulizer, brilliant. It means no disconnection and it's a little bit faster. But if you don't, the T-piece ones work just as well. Back to you, Jess.
So just to finish off this case, just to kind of bring out a few points. So I think in a child like this, and we see lots of children like this, it's really important to just think about the interplay between seizures, dystonia, their respiratory status and their secretion burden. If we allow them to be dystonic, that will generate more secretions. if they're uncomfortable, they may well seize, and we may need to give them benzos, which will depress their respiratory drive and their cough. So it's really important that we think about their neurology as well. So we follow any dystonia management plan they have, but we just really think about their comfort. So paracetamol, having a fan, thinking about whether they might be hungry, and that might be making them distressed and not tolerating their NIV, and then just talk to parents about what they like and what makes them comfortable. It's also important to think about whether they're tolerating the respiratory support. If you're using CPAP and they're uncomfortable on a high PEEP, you might want to start on a lower PEEP and increase that slowly, or use a ramp if you can do that on your ventilator. And if you've put them on BiPAP, which many children, neurodisabled children, are more comfortable on BiPAP than CPAP. If you're doing that and they're not synchronizing well, then thinking about your settings. It's really important that you do good skin care and do good face care, because they may be on NIV acutely for a week or more, and if their face breaks down, then you won't be able to continue using it. So we use Sil tape or Kerapro usually on the pressure areas, the areas where the mask is exerting pressure, and just making sure that the mask is not on too tight, and all of those things. We've talked about antibiotics and nebulizer delivery, and Mel also talked about their anticholinergics, so their glycopyrrolate and hyoscine, which we would usually stop when they come in acutely unwell, and then we would work with the physio team to reintroduce it later in the illness if they're having copious loose secretions. And then with a patient like this, we need to think about avoiding ventilation if we can. This child will probably not do very well on PICU because of his severe restrictive lung disease and his difficult secretion management. But then if we are going to intubate him, we don't want to leave it too late until he's peri-arrest. So we need kind of senior decision makers from both the consultant, pediatric and an anaesthetic team to kind of make that call and make that decision. And then of course, a child like this, there should be ongoing conversations about what escalation is appropriate for them, and talking about whether they have an advanced care plan and whether those conversations have been started. And then just really quickly, we won't go into mask fitting, but SCPN have a great resources on mask fitting, so have a look at those. But normally in the acute setting, when if the child is very hypoxic and unwell, we would start off with a total face mask or an oronasal mask, as that will give more support. But as they improve, and particularly as they wake up and become more uncomfortable, and often children may not tolerate the full face mask or the total face mask, we would want a nasal option as well. So sometimes we might start off with a full face mask and then give them kind of breaks on nasal pillows for older children, or a nasal mask for younger or older children. Okay, so we'll move on to the second case, which I think we'll need to do quite quickly. So this is a 2-year-old. She's an ex-prem. She's got a tracheostomy, which was put in at around a year of age due to severe subglottic stenosis and bulbar palsy, but she's not ventilated at home. She's only just been discharged from hospital after being there till she was about 1.5. She went home 4 weeks ago, and she's been doing well at home since then. And she's got some mild global developmental delay, but she's actually very active, so she can kind of cruise around her cot. She likes jumping up and down in the cot and crawling around. So another blue call to resus. She's had 2 days of fever, cough, and she's been vomiting a lot today, so 8 or 9 times. And mum's called an ambulance because she's got increased work of breathing and she's been desaturating and they don't have oxygen at home. So our A to E assessment. So this is our A assessment. So you can see she's got a size 4 trachea in situ, peds vibona flextend. They suction her down to a depth of 9.5 with a size 8 tube. And ENT have said, yes, her airway is intact, but it's a difficult airway. So she's got subglottic stenosis. And they've helpfully said that you can pass a size 2.5 ET tube if you need to. And then moving on to B, so LAS are giving her some face mask oxygen, but her SATs are only 90%. She's tachypneic, she's working hard, she's got decreased air entry throughout, creps and wheeze. She's quite tachycardic, and she's very distressed. She hates any doctors and nurses, and she's febrile. Nothing of note on E. And that's her x-ray. So you can see her trachea's in situ. She's got some right-sided changes here, which may or may not be chronic. And this is her blood gas, which is actually okay, isn't it? Kind of very mild respiratory acidosis. You can see she's been vomiting all day, so her glucose is a bit low. So just really quickly, how would you manage this child differently from our previous child?
Give her oxygen via trachea. Yes. Yes, we put that in, and that face mask is often given with a trachea patient, and with that subglottic stenosis, we just don't know how much it is going to be getting down there. So perfect. We want something to be going into the airway that we've got. Brilliant. Yeah, brilliant. Humidify, yes, we don't want that dry 15 litres going in. Those secretions are not going to like it. All the other things that we've talked about. This is great. I'm going to be really quick and I'm going to start moving on because I know we've only got, I want to get to people's questions as well, but brilliant. Sounds like there's loads of great ideas here about cuffs, bronchodilators, brilliant. So that's going on to the management.
Thank you. Yes, so we need to give her some respiratory support via her trachea, don't we? So yes, we can definitely use oxygen. If she's got a Swedish nose, she's likely to have somewhere that it's got a port where you can attach oxygen, and we'll have a look at that. But that would certainly be what we would need to do in the first instance, so that we're improving her saturations. But if she needs more support, and particularly more humidity, we could also put her on Optiflow or CPAP or BiPAP via her trachea. Do we need to change her trachea? So it's patent, so we don't need to change it in an emergency, but it might well be coated in secretion, so that can be an indication for changing it. And also, if she's been vomiting a lot and she's continuing to vomit, she might benefit from having a cuffed trachea. So you could think about changing the trachea to a cuffed one to prevent the risk of aspiration. Again, I can see that there's lots of things in the chat about wheeze, which we can talk about again. It's obviously difficult to tell whether the wheeze is caused by secretions or bronchospasm. So again, if she's a trachea child with secretions, some hypertonic saline may help with that, but we may want to use a bronchodilator with that. And fluids and feeds, as we said with the previous child, this child's got a low glucose, so we certainly probably need to give her some dextrose in the first instance, and as soon as she stops vomiting, we should introduce some diarrhea and after that some feed. And actually this is a child who's orally fed usually, so for this child we would need to put in an NG tube, which we can use for aspirating air from her stomach in the first instance, and later on for feeding. And then we've again called out our on-call physio.
So I won't reiterate lots of the stuff that we've already said due to time. But what are we thinking of differently? Well, one of the big things I like to highlight is 0.9%. So you've lost that upper airway part, the nose and the mouth, to be able to humidify and warm that air. So this is when the 0.9% can come in and can be really useful. The same as before, but we've got suctioning of our tracheostomy now. We've got different airway, but still don't forget your oropharynx and nasopharynx, because those areas can get blocked as well, and they can be getting some ventilation through that area. And this child's not cuffed, so therefore you might get some air going through that route as well. Looking at the depth, looking at that chart, how far can you go down, keeping into that tube, unless you're trained otherwise to be able to go deeper, but you've got the risk of the granulomas. That's not something we recommend, but that is something that could be an option if you've gone through the tube and you're still having issues with some of those secretions. And that is, again, something the physio will be trained at being able to do. And the same as before, secretion management. And the other thing is positioning. I'm not putting the positioning slides on again, but you've got to think of this child a little bit more active, a little bit less compliant with you, and may not want to be so compliant with your positioning and your physio advice. Moving on to reassessment.
Yeah, so we reassess her. So we changed the trachea. It was patent, but it was really caked with thick secretions. We decided to put her on some Optiflow actually, so that she would be receiving some humidification as well as oxygen, and her work of breathing improved. She was given some 3% saline and some salbutamol, and they were able to suction copious secretions from her trachea. Her heart rate's improved a bit. She's now afebrile and feeling a bit better and sitting up and watching Peppa Pig. And we've put in an NG, which we've put on free drainage, particularly now that we are giving her flow through the trachea.
Physio-wise, is very similar to before. But you just might be able to involve the child more in the activities that you do. You might be able to do those manual techniques, but if she's a little bit professional phobic and isn't so keen to be handled, could the parent do it? And trying to think about ways in which they can be involved in what you're doing, but also looking at some of the comments as well. You need to think about, I know people don't like that comment wheeze, but you want to be knowing if you're making things worse. So sometimes you have to, as I said with the last patient with the PEEP, you need to think about short sessions that are effective, because these children get quite distressed with you handling them. So you want to make sure what you do in the short time that you're in there is as effective as possible.
Yeah, so just really quickly, some ways of delivering oxygen on the left through a mask or directly through the Swedish nose, and then the trachea Optiflow connector, which are widely available. And really you set up the Optiflow in exactly the same way and then just put it through the trachea rather than through the prongs. And then if you're putting a trachea child who's not normally ventilated onto your own ventilator to deliver CPAP, don't forget to put an exhalation valve in. The exhalation valve may look different depending on your ventilator and your circuits. All children with a trachea, whether they're ventilated or not, will come with this trachea case. Sorry. Yeah, if they haven't got it, then they need to go back and get it straight away, but they should all come with a trachea box, and it's important that the first thing that the nurse taking over the care does is to check that all the contents of the box are there. And then for departments that don't see trachea patients very often, it's really important to have the emergency trachea management algorithm up in your resus, so that you can make sure that you're doing trachea life support properly, and that people aren't panicking because they've forgotten the stages. Trachea is a really good thing to sim frequently, and also we do lots of kind of in situ trachea skills and drills, which kind of take 5 minutes. So if anybody wants, I can share sims and little trachea skills and drills, but it is something that scares people, but actually if you have done some sim, that really helps.
This next slide is just a very quick one. I like flowcharts of what you could do. This is for a trachea ventilated patient, again from St George's, but making it bespoke. I know people were talking about sort of that wheeze, and if you can make it bespoke, then you can put those signs of increased work of breathing into this bespoke program. And then with a tracheostomy patient, just adding in that extra bit of, is it patent? The things that you could do, the things that maybe are being done at home, and moving on to the things that could be done in the hospital, which we've talked about today. This is just a slide to say STPN have some guidelines on NIV. You've got the tracheostomy safety project as well, which has got great information. I've got those charts that Jess has put up there, and there's the QR code for it. And you've got the link for STRS retrieval service and their contact there. And just finally, the contacts for LTV education, and we have an e-learning for LTV that is accessible to everyone with an NHS email address.